last but not least, the case discussion with polling. You are all invited to vote. And I would like now to invite the panel members, Professor Milella, Dr. Rzyman, and Dr. Dziadziuszko, and Dr. Cardillo will be online.
Hello.
So briefly, this is the first case. You can see this ground glass lesion in the right lower lobe in an 80-year-old former smoker who had a history of colorectal cancer and some comorbidity. And this is the beginning of the story. So what would you do in this case, considering that the patient is elderly with some comorbidity and a history of previous colorectal cancer? She also had adjuvant chemo.
Can I ask radiologist if this is pure ground glass opacity or this is part solid? This case.
Can we go back to the
We have radiologists here.
Can we have the, okay, I should do it, okay. So you can see that.
It has no?
It's a small solid component,
Solid.
very tiny.
And since he had previous colorectal cancer, did he have a previous CT scan before this one?
No, this was a follow-up CT scan after a colorectal. So 2018, and this all started in 2019 or probably, if I remember well, it was simultaneous. No, 1 year later, sorry, 1 year later. So we see that 44% of attendees would rather wait and follow. This is the most voted option. What would you do, Dr. Rzyman?
Well, in this case, I think I would. I want to have definitely the follow-up scan, but after 3 months, first to see if it's not it disappear, and if this not disappears, it is seems to be big one, more than 3 centimeters. So then either follow up with 12-month CT or FDG, no, follow up. One, if nothing has changed, I mean the tumor or the tumor is nodule is the same. Follow up after one year.
Professor Dziadziuszko?
The same in our institution. I will consider PET scan because of the
Maurizio.
I'll consider PET CT scan because of the history of cancer, colorectal cancer, not so long time ago. Although the morphology of these doesn't look like metastasis, looks like GGO with solid component suggesting MIA or so follow up 3 months and PET scan.
Yeah, I completely agree. I would go for follow-up with this kind of lesion. Usually we always get almost always not so clear answers from FDG, but very usually you have some low-grade uptake and then you're always in doubt of what it is. Also, I think it's very important seeing the history to know what the level of risk of his or her colorectal cancer was. So was she likely to have metastasis, or maybe it was just a T1?
No, it was an N1 cancer.
So I would definitely go and see how the lesion changes over time.
Okay.
I fully agree. The only reason to do PET CT scan is cancer history to rule out other metastases. So that's a little bit different than the patient without cancer history. And the cancer history was not so long time ago. It's 1 year and something. So that's the reason for that.
Okay. So we follow on.
Maurizio, can you hear me?
Yes, I can. Are you Giuseppe?
Yes, yes,
Ah, oh, you're welcome to express your opinion.
yes. What I would like to say my opinion about the imaging. First of all, the imaging is not seems to be for lung cancer met. So it does not seem to be a met. It's a part solid nodule. What I would like to ask for the future is that when we see a part solid, we try to measure the solid lesion within. That's very important, because if you ask to your radiologist and you discuss with him how big is the solid lesion, if it's less than 5 millimeters, then you can be very comfortable with that. But when it's more than 5, then it's very suspicious. So in this case, it seems to me very suspicious. This is my personal opinion regarding this part solid nodule.
Thank you, Giuseppe. Does anyone want to express? Otherwise, we move on in the interest of time. So this is what happened 2 years later. We followed, and this is what happened. At that point, in the beginning, we did take a PET scan, which was just barely positive. 2 years later, the PET scan had become frankly positive. The solid component had grown. So what would you do next? Okay. So
a surgeon should answer operation theater, and
we have to be able to read the question.
I will go on with biopsy. This is what we are doing. Always biopsy before surgery.
Please show the questions on the screen. Right. Okay. So 52% of the audience would just take a biopsy and then decide what to do. What do you think, Rafa?
It's a typical case that we will consider stereotactic radiotherapy versus surgery based on comorbidities. It's 81 patient with multiple comorbidities. So we would rather consider stereotactic before surgery, and we would typically go for biopsy. If there are contraindications or pulmonary function is compromised, which is not the case here, we'll go for stereotactic treatment without biopsy, but based on PET scan only.
Okay. Professor Milella?
Yeah, it very much depends on the comorbidities and conditions of the patient, because I believe that whether it is a single met slowly growing after 3 years, and we are sure by PET CT scan that there are no other colorectal cancer mets, or a primary, definitive treatment would be appropriate anyway. So we don't really need to know by biopsy whether it's one or the other if we go for definitive treatment.
Okay.
Then, of course, which kind of definitive treatment might be discussed with the patient, because he's an elderly patient with comorbidities and so on.
Sure. And Giuseppe, would you like to add your comment?
In my opinion, I think that the most correct procedure is to do directly to VATS biopsy, frozen section, and eventually segmental lobe. My opinion, how it shows now, it's very clear to be a lung cancer, absolutely. Now, when the solid component is increasing, it's a clear evidence of early stage lung cancer if it's within 5 millimeters. Otherwise, can be an invasive adenocarcinoma. So I think no doubt can proceed. In my opinion, since the beginning, I was very suspicious with this part solid, because if you compare solid and part solid, the percentage of lung cancer in part solid is much higher than in solid nodule.
Yes, Professor Aloisio, would you like to comment and then decide. Okay.
But if I can add something,
sorry.
You would like
what Rafał said, we will definitely discuss this case starting with stereotactic radiotherapy as a primary treatment, because this patient is healthy. This particular patient is healthy, 80 years old, but without no compromised status, hypertension, as I saw, something like that. So basically, this is fit patient to surgery. So I wouldn't say, Rafa, we have
No,
this
he's not healthy. He had look at the very beginning. He has. Can we look at the medical? No. Look at the medical history, please.
And
Hypertensive cardiomyopathy.
Yeah,
so
but
it
mild.
depends what kind of cardiomyopathy. If the ejection fraction is 25, would you proceed with surgery? He has a type 2 diabetes. That's another story. We know that diabetic patients are on the higher edge of complications from surgery. So the cardiomyopathy story here does tell me that it's not a fit patient. We would need to see patient, of course, and we would need to see echocardiogram as well.
So there is a comment from the audience online. Wouldn't it be safer to undergo surgery after knowing pathologic diagnosis? In principle, yes, unless you are pretty sure, this is my opinion, that it's cancer, it's grown, it has become PET positive, it does look like an adenocarcinoma. I can tell you it was. So, okay. Okay, I think in the interest of time, we should move on to the next case. Thank you everyone for their comments. Okay, this is case number 2.
You didn't tell us what we did.
You didn't?
How did
sorry,
it
sorry. Yeah, the patient, we discussed with the patient, she opted for primary surgery. So we went to the theater, the OR, took frozen sections, of course, to confirm the diagnosis, and then she had a lobectomy, and she is currently disease-free 3 years later. Yeah. So, but I mean, primary treatment of the local disease was an option in any case. So this is case number 2. She's a 42-year-old never smoker with a history of previous uterine cancer. This was an incidental finding, okay? She had a CT scan. There was a lot of discussion about whether this would be a granuloma because of the location, because of the young age, and because she was not a smoker. So, Paul, please, what would you do now? So I can see that most people here would just go straight for the biopsy. This is the end of the story, I'll tell you. The cancer, yes, she was good. Yeah. Yes. No. She was disease-free.
Sorry, Maurizio. Here I am.
Sorry.
7 PET scan. Why not?
Was not done.
There was a previous cancer.
Yeah. So what? There is no other. You said.
Yeah, we were discussing among us the possibility to give a PET scan before going for biopsy.
We have a very experienced thoracic radiologist who, by the way, is the one who designed the BIMC calculator that was discussed yesterday. And yeah, he was a bit against it. So in the end, what we did is we offered 3 months follow-up with volume doubling time measurement. This is what we did. Sorry, would you?
No, because in this particular case, I think personally that this patient with uterine cancer, I would go with PET scan actually after 3 months to have both to estimate the tumor, but also to see if this patient with uterine cancer has no other metastatic disease. But if it was negative, I would propose immediately surgery. Why? Because it's a very simple case. It's just VATS excision in very good placed, well, in the apical part of the lung, so very easy to do the VEG, and it shortened all the way. She doesn't need to next additional follow-up after 1 year, and so on and so on. So PET scan after 3 months and surgery.
Well, I would be hesitating between PET scan and simply CT scan. The problem with the PET scan, though, is that this will not show us what is the primary, whether that's granuloma or whether that's metastasis. The good thing about potential PET scan is the potential look for other mets. So this is a valid option. Probably CT scan in 3 months from this time would be my option.
Is very high, so I think that everything we've learned today says that we can't do that 3-month wait.
I agree with, but look at the patient's history. It's a 42-year-old never smoker. So the chance that she has a primary lung cancer is very low, as opposed to the previous patient with high smoking history. So we are much more comfortable for 3-monthly follow-up in this case.
And also,
It was
and also, which makes me think that her uterine cancer might be an aggressive type. So that would actually increase the probability that this is a MET from uterine cancer. And with the therapeutic options that we have in uterine cancer today, I would make sure I'm not giving her a useless lobectomy.
I should add that it was an early stage uterine cancer by that time. But okay.
Maurizio,
Yes?
Maurizio, may I say my opinion?
Yeah, sure.
In this case, in my opinion, this patient is young, and it looks, as far as I know, fit for surgery with oncological anamnesis positive. So in my opinion, I would go to skip biopsy. I'm not very keen to offer biopsy, CT-guided biopsy in this patient. I should ask her for her PET scan, because I always do PET scan before thoracic surgery, and then directly resection. So intraoperative examination and resection. So that's my opinion. Fit patient should undergo directly to surgery, as according to NCCN guidelines.
I see that the case is very controversial.
It is my opinion.
Infection looks exactly like malignancy. So this is the reason I think we should wait.
This is the reason why we did not take a PET scan. This is our reasoning.
And
I see.
History is everything. And in the local context, if we have this meeting in Egypt in January, this will be TV.
Sure.
And in fact, I have a good friend, very affluent, living in America, but American Chinese. And I referred him to Cleveland Clinic, TB. So I think you have to depend on the context.
What time is it? Okay. Okay, I'll show you what happened next now. Okay, this is the same case. We took 3 months delay and did the volume doubling time measurement. Volume doubling time was 482 days, which is very long. The lesion still looked suspicious to us. We did take a PET scan, which was mildly positive. And still, we decided to discuss with the patient. But now what would you do? Well,
Yes, I have already operated her.
Hmm?
I have already operated her.
just so which one is the most likely diagnosis in your mind?
Inconclusive diagnosis. If you have volume doubling time 4082, this is the worst that you can have, because between 400 and 500 you have, still 20% possibility of having cancer, despite it is long.
Okay, I see most of you favor a cancer diagnosis. Okay, we can stop the poll. And so did we. So the patient had a lobectomy, frozen section, and lobectomy in by VATS. She's now doing fine. It's 5 years ago now.
What was it?
Adenocarcinoma, sorry. It was an adenocarcinoma.
Being an overdiagnosed cancer, so in a non-smoking woman, which
Right.
of course is insanely, but that was published recently.
But was it a primary lung or was it metastatic?
Primary. We did intraoperative biopsy. When we think that the suspicion is high, because we always think about the false negative or failed percutaneous biopsy that would leave you basically again at the same point. What do you do if the biopsy is non-diagnostic? So we sometimes decide, we discuss with the patient, we go for a VATS biopsy, which is a minor procedure. If it's positive, then we complete with a lobectomy. This is it. So is there another? So this we can skip now, case number 3. So this was very controversial, even in our department. You can see that huge lesion, very ugly looking, in a patient with some comorbidity, quite some comorbidity, including Mediterranean anemia, thalassemia, so low hemoglobin level, and Jehovah's Witness, so he would refuse transfusion. Okay. We did everything we could to make a diagnosis. EBUS, percutaneous biopsy, none of it was conclusive. What would you do now?
Definitely redo biopsy.
Agree.
Yep, me too.
They tried bronchoscopy, and we got a percutaneous biopsy, the result of which was the following. I'll show you. Okay, this is a biopsy, and you can read what was the outcome. Yes, it's in the periphery. Definitely in the periphery. Okay. So now, what would you do?
I would propose redo biopsy immediately, the next one, without waiting.
Send the slide to the pathologist, to another one for consultation, maybe. Yeah. Yeah, okay.
You cannot say that from the biopsy, can you? Can you say that from the biopsy of typical pneumocyte proliferation? Yes.
Lesions. I used to get that all the time. The pathologist eventually got comfortable when you'd say, hey, this, especially with the ground glass lesions, non-solid, they always say atypical pneumocytes, until we realized that that was 100% of the time they were, with the right picture. This is not
Former
quite the right
bronchial
picture.
velar carcinomas.
Yeah, that they're
I-
always.
In this case, I think that if the material was enough to do molecular profiling, I would look for EGFR mutation given this kind of diagnosis, because if it's a mutant, you have a diagnosis of cancer too, in addition to the target. With this characteristic, if the material is enough, I would extract DNA and look for EGFR.
Okay. So I see that there is quite some debate about what to do, but most of you favor surgery.
Not
So-
in this patient who is Jehovah and with so low hemoglobin level.
Beg your pardon.
Not in this patient. For me, this is not the candidate to surgery as a Jehovah Witness. Especially if you want to do it, I mean, open surgery maybe, but if you want to do it, VATS.
Okay, can we move to the next case? What was it? The patient was informed of all options and he opted for primary surgery. So he had a VAT lobectomy and we crossed our fingers. We did not have to transfuse.
And what was it?
We don't have the final pathology yet.
Not yet.
It was an adenocarcinoma.
Next
but,
week.
Ask for molecular.
It was carcinoma.
Yes.
It was carcinoma.
Yes.
You must be very convincing. They're all opting for surgery.
Well, maybe they come to me because of that. Okay, I think this will be the last case because we don't
Can I ask one question, Rafał? Just one simple question. In this patient, could you do stereotactic radiotherapy, or this tumor is too spread, too big?
It's too spread, actually. I would need to look again, but it's not a good candidate for stereotactic treatment. Yeah, we would need to see another one, but the previous case, but it doesn't look like a good candidate if you don't have a good. If the tumor is large, first of all, our upper margin is somewhere between 4 and 5 centimeters. We are typically not doing SBRTs in tumors larger than 5.
I would like to
And-
thank Dr. Martin for this,
Yeah.
this interaction.
So
Sorry, Rafał.
in brief, I would need to look at the scans very, very carefully, but it's not a good candidate for stereotactic treatment. You're right, that would be a right thinking in terms of blood supply during surgery, but it doesn't look like to be a good alternative for lobectomy.
Okay, so the last case now. Okay, thank you. Now, this was a 70-year-old current smoker in a very good shape. She was an entrepreneur, very active woman who had a lobular breast cancer almost 10 years ago, which was an N1 disease with good hormone profile, you see, and had a recurrence, an axillary nodal recurrence 7 years later. So she was on abemaciclib and fulvestrant, and she had a completion axillary dissection in 2020. So in 2021, you could see those tiny nodules here, one and the other one here, with a hazy halo around it. What would you do? What would you think is the most likely diagnosis? Can you show the poll now, please?
How big is the tumor in the upper lobe? Do we know the diameter of this tumor in upper lobe?
I don't remember exactly, but it was less than 1 centimeter in both cases.
Less than 1 centimeter.
You see. So what would be the option? What do you think it is? Beg your pardon? Okay, you think it's metastasis, so what would you do? Anti-cancer therapy, follow-up, what? Stereotactic, what would you do?
So the patient is on abemaciclib and fulvestrant now?
Yeah.
Yes.
Okay.
So what I can tell is
I would follow up with the next scans.
follow. Okay. So
Agree.
she was, okay, we did follow. And next slide, please. So 2 years on, 2 years later, there was no spread outside the lungs. So the breast cancer cells, if any, were under control. However, the two nodules were growing. As you can see, they became PET positive, and both of them. Okay, so what would you do next? Paul, now, please. Yes.
And middle lobe. Middle lobe. Biopsy.
Biopsy.
Me too.
These could be two primaries because this is progressing on hormonal therapy on which the patient is very likely to benefit from, or that could be true progression from breast cancer.
Okay. The oncologists who referred this patient, they said they did not have the expertise to carry out a percutaneous biopsy on the upper lobe lesion, and had already spoken to the patient proposing surgery. So she came with a clear idea in her mind.
When is my surgery scheduled?
Something like that. So because there had been no response to anti-breast cancer therapy, we were pretty much convinced that there would be new primary tumors. And we accepted their proposal. The patient went to the operating theater and got intraoperative biopsy of the upper lesion. There was an adenocarcinoma, not otherwise specified, obviously on frozen sections. So she had a lobectomy and a wedge resection of the right middle lobe. And they were two different adenocarcinomas primary. One, the middle lobe was lipidic predominant, and the other one was a micropapillary acinar adenocarcinoma, where they were both node negative. And so the patient has been discharged 1 month ago. She's doing fine. So this is the end of the story.
But what was the period between the first CT you showed us and this one? 2 years?
2 years.
It's definitely too long. I think she missed. Yeah.
Well,
Yeah.
they followed her and then they referred. So this is the end of the story. There would be more cases, but I think it's time to go. And thank everybody for participating. And now a few closing remarks by Dr. Jankelevich and Claudia. Me, thank you.
Maurizio, excellent presentation, actually. This is the meat of what we do.
Thank you very much.
Thank you very much. Thank you very much, Maurizio.